trial is?
Yeah.
And what does that entail?
Taking your patient off of sedation.
To see if they can breathe on their own.
Okay, and what's the first step in a spontaneous awakening trial?
To see if the reason why they got intubated is resolved.
Underlying.
Okay, that's, the answer here was to overcome the patient's first reason to be intubated. So that's a good one. What else? So you want to decrease your medications until they're at what?
0.
0 if you can get there. Chances are you probably won't. But here's the fine line. At what point in a patient's sedation scale would you say, yeah, I could probably get away with extubating this patient and he's going to do fine? How do you make that decision? And who makes it?
The doctor makes the final decision.
Who makes it?
The doctor
And
you.
and you. This has to be a collaborative effort. If you've got physicians who are working in the ICU who they don't engage the opinions and the expertise of RTs, nurses. When you guys were in your ICUs, did you have team rounds every morning?
Yeah.
How many did? How many didn't in your ICUs? You didn't have.
Night shift.
It was what?
Night shift.
Oh, it's night shift. Well, even so, they should have shift to shift. Yeah, at least some type of rounds. You may not have all the players, PT, dietary, case management, all those people. But all those people, were those the people I just mentioned? Were they present in most of your rounds?
Yes.
Excellent. That's what we wanted to do when we started launching this ICU Liberation program. Sutter was the first one to do it, and then it caught on really, really fast because we figured out, hey, we want to get these patients out of here and off the ventilator. So we were lucky because most of our patients are not the real train wrecks like you described as patients that every time you turn over, they're sat tanks. And what are you going to do? Well, you got to prone them, or you got to do all these weird things to try and save them. The statistic for ICU survival rate is actually pretty high, but the incidence statistically of PTSD is very, very, very high, very high. There are 3 things that would cause a bad PTSD. What is that? Physical assault, murder, ICU stay. And it's in the top 3 of those things that would cause PTSD. I have had patients, and back to Dr. Ely, the guy that I told you about. He's got that website is fantastic, and he's a really, really nice guy. He came to San Diego one time. We sent a whole team down from Sutter, and that's where we got introduced to this liberation thing. And it all had to do with decreasing ICU delirium. He mentioned a patient, and we've seen a patient since then, that a 45-year-old, she was an accountant, and a 32-day stay on a ventilator in the ICU, and after that, even 6 months later, she couldn't balance her checkbook. So it was that bad. We had another patient. He is actually he travels around and tells his story. I'm going to see if I can get him to come and talk to you guys. But he was, do you remember H1N1? Remember the scare with the H1N1? This guy got H1N1. He was on a vent at, I think at one of the Sutters. And when he finally recovered, he had these recurring nightmares. And one of them was murdering his daughter. And he kept having these recurrent nightmares, the same thing over and over and over. He was on stage telling his story, but all of a sudden he stopped. And people were silent, just like this. He said, "I'm sorry, I just had that nightmare." Standing there in front of us. I was thinking, oh man, this is what we did to the patient. He said, "Oh, I remember the people in the yellow outfits, isolation gowns. Yeah, you were trying to hurt him. So these are some nasty things that can happen from ICU sedation. So be careful when you're doing that. How many of you have been in a scenario or an ICU where your weaning times are only in the morning? Typically only in the morning. Okay, so we come in, we do our SAT, we do our SBT, and the patient failed the SBT, put them back to their settings, and walk away for the rest of the day. Sound familiar? Okay, why should that not be? Are we giving the patient a chance? No. Our protocol was if you had an SBT failure, you put the patient on half of the support that they had, and usually it's just a CPAP of 5. We put them on CPAP with a pressure support of 5, or no, CPAP of 5. Let them breathe spontaneously, but if they can't pass that because they're sedated, then go back to sedating them, but only at half the dose that you just did. Does that make sense? Started with half a dose, and usually you'll wind up being successful. So do it in stages. And as I said, we don't typically do a formal spontaneous awakening trial. It's more a part of a PAD guideline, the pain, agitation, delirium. How many of you have heard of a RAS score?
Yeah.
Okay, has that part of what you guys have learned here? Yeah. Okay, and a CAM score, confusion assessment metric, the CAM ICU score. Oh, that's a trip. You ask your patient. You ask your patient 3 questions. Can you pound a nail with a hammer? Does 1 pound weigh more than 2? And are there fish in the ocean? And why are you asking those questions?
Their motor function.
To determine the presence or absence of organized thought. Yes. So that's and if they can't do that, it doesn't mean you don't extubate them. It just means you've got a little bit of work to do. So you may want to just back off on your sedation just a little bit. So you've got the patients that are sedated, but why are they sedated? Are they doing something they're not supposed to be doing? How many of you have seen patients that are moving in the bed and are not allowed to chemically? So we sedate them. Anybody ever seen that happen? Show of hands. How many of you seen that happen? And what was the outcome? Yeah. What was the outcome on that particular patient? Do you remember?
She was off the vent and then she had to go back on the vent again.
She had to go back on the vent?
Yeah.
Okay. So on the vent, that means she had to be re-intubated?
No, she had a trach.
Oh, she had a trach.
Yeah.
Okay. Okay.
But because this poor lady was in ICU the entire time I was in the hospital the last day, and the nurses would snow her at night because she'd end up removing, she'd be tied down. I mean, it was really an awful scenario.
And how long was your rotation at this hospital?
Over what? 2 months?
This patient was in an ICU for 2 months, trached, on a ventilator.
On a ventilator, off a ventilator, on a ventilator, off a ventilator. It was an awful scenario.
So this was an acute care facility.
No, this was at Mercyful.
Yeah, that's an acute care.
That's an acute care facility. So the patient did not go to a long-term facility.
She was at a long-term facility, came in because she had pneumonia. And she was there probably a week before I got there. And she's still there in ICU.
Wow. Wow, that's
And
amazing.
It's really, I mean, literally, one of the weeks that I was there, they literally had her up and walking. PT had her up walking. She was on the bed, off the bed. We took her outside, everything. The next week I went back, she's back on the bed. It wasn't because she had pneumonia or anything like that. It was because at night she would want to have more mobility, and she would get frustrated because nobody was there sitting next to her. She almost needed a babysitter. And the nurse would snow her, and then snowing her would depress the respiratory, and then they put her right back on to the bed.
Yeah, that's a bad cycle. That cycle, hopefully somebody will figure out how to break that.
No, I'm hoping to too, because every time I go into the room, I talk to her, you know, and
Was she with it?
sometimes she was, sometimes she'd smile at me,
Okay.
you know, sometimes she'd grab my hand, you know, she had the mitts on. It was kind
Sometimes
of.
she'd clench your hand. Yeah, help me, get me out of here.
In all reality, as a student, it's kind of traumatic seeing stuff like that.
Yeah.
Can I interrupt for a quick second?
Well, hello, Miss Prophet.
Mr. Sammons?
How are you?
Say
I'm
hello.
good. I have to give this gentleman a hug.
Long time no see.
How are you?
Better now that I see you.
Thank you. Oh, thank you. You guys are so lucky.
Can we turn our homework? Yeah, can we?
Oh, calm down. See you.
See you later.
So cute.
So yeah, that was the scenario. But you mentioned one thing that I forgot to include in this ABCDE bundle. One of the things that you want to try and do also is how many of you have been in your ICU rotations, have gotten your patient out of bed and walk on a ventilator? Where was that?
Kaiser Roseville.
Kaiser Roseville. Where was that? Marshall. Good for them. Yeah.
I've never seen that.
Yep. Yeah, there's a gal up there that used to work for me, Jamie Herzl. Yeah, she used to work for me up there. She lives up there. A lot of patients, we used to not have ventilators that had onboard gas supply and onboard power supply. So it was extremely difficult to get these patients, up and out of bed. Now we've usually got a team approach. So it's in the DNA of a physical therapy department. It's in the DNA of the RT department. Everybody teams together: an ICU nurse, a physical therapist, a respiratory therapist, another support person if we need to. But you get the patient out of bed and actually walk them. Prior to the ability to ventilate them on a ventilator, we used to call it a dragon bag, because we would bag the patient and let them walk. It was extremely difficult, but it was moderately successful. But now that is coming around full circle. It's being resurrected, so that we get these patients up and out of bed. So that's the mobility part. We want to try and do the mobility. What else about sedation and paralytics in the ICU? Oh, one of the things I wanted to, I don't know if I want to do that here. Well, what the heck. Anybody know what train of 4 is? Everybody ever heard of it when you're administering paralytics? No? Train of 4 is the way that you measure. I mean, when you've got a patient that is paralyzed, they can't tell you how they're feeling. They can't tell you their pain level. They're paralyzed. Even if they're intubated, they couldn't tell you. And even if they're extubated, they wouldn't be able to tell you. So how do you know? And how do you know if, I'm sorry, what?
Are you talking about the little leads right here?
No, that's one. Yeah, that's one method. Yeah, that's one method of assessing neuromuscular blockade. What she's referring to is called a BIS. It's a bispectral encephalography, where you have 3 electrodes in a strip across the forehead. It's hooked up to a monitor, and the monitor transmits or translates 3 of your brain waves, alpha, gamma, and one other, into a number. And 0 being dead, 100 being fully awake. And so you want your number to be 50 to 60 right in there. But it's a way of monitoring the patient's brain waves. But I also want to know if the neuromuscular blockade is working. That's a sedation thing. So how awake is the patient?
I was talking about the eye twitch, when they count the twitches in the eye.
Okay, so they were using a thing with 2 electrodes, putting it here. Yeah, you can do it here. Usually it's on the hypothenar. But yes, that's exactly what we're talking about. So the way it looks is, These are identical electrical twitches. You put a thing with two electrodes, either here or here, on their face, and it administers. It's a little box. And another thing I used to sell, neuromuscular transmission monitors. But it'll have the what this represents is the repolarization ability of the muscle cell at the myoneural junction. Everybody know what I'm talking about? So the nerve conduction comes down, and it's right next to the motor end plate, and acetylcholine goes across, and bang, you got a contraction. Everybody make sense? Remember that? Okay. That impulse can be artificially created so that what you're going to look at is this thing's going to give you the same voltage every single time, but what you're looking at is the response and how fast the muscle can recover. Okay? So it's going to look like bang, 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 bang. Same, that's about how fast it is. So this one is stronger than this one. So this is what you want. You want what is known as fade. And so in your scenario, how were they monitoring this?
They had the little box, and then they were counting how many times the eye twitched.
Okay.
And then if it was like 0, it was too much.
Right.
And if it was 4, it was too little. They wanted like a 1 or 2
Yeah.
eye twitch.
Yeah, yeah. So they're right in here is what they want. So that's called a fade. Yeah, so they wanted enough fade so that it's not 0, but not so much that it's it's a complete closure. One more tip about conscious sedation or procedural sedation is the eye flick. Everybody use that? You flick the eyelash with your finger, and if the patient blinks, they're not under. Anybody ever see that? No, that's how I would test patients. Do it to yourself. Flick your eyelash, you'll blink. Yeah, so you're taking away that reflex when you do that. Everybody follow this? It's not a huge thing, but you might see it. So when you hear that train of 4, you'll know what that means. It's in reference to neuromuscular blockade. Okay. Anything else I can cover for you folks? Let's go outside the box and anything else? Mechanical ventilation, anything? Yes, sir.
I don't know why I struggle with this one. So a spontaneous tidal volume, I get that. They're spontaneously breathing. What's the return tidal volume? How do you chart that, and what is that? When you're watching on the monitor.
Are you talking about dialed in versus return?
Let's say I'm doing a vent check, and there's the two things. There's, you're charting. One's the spontaneous, the spontaneous tidal volume, and then the return tidal volume. How do you differentiate between the two? I mean, I can understand the spontaneous one. I can see that. I just don't know how you chart the return tidal volume.
If they're different, why would they be different?
Inhalation, exhalation. Or one's their own breath and one's given to them by the ventilator itself. Okay.
And is there positive pressure being exerted to the chest?
Yeah.
Okay. So they're on pressure support.
Right.
Okay. So how much of that is actually being exhaled?
That would be.
Are they air trapping? Do they have dead space?
So wait, how you would mark down the return is just the difference between the set pressure tidal volume?
You should have both. It should say both. So you're talking about going to a machine and you're looking for this number to put in a box on a form.
Right.
Yeah. So I would use the return tidal volume because that's the amount of air that has effectively gone to the alveoli. Okay. If you had, what does that spontaneous breath include? Anatomical dead space.
Okay.
Yeah.
So you'd look, because like this is on like the G5, so you could see the spontaneous, how it would have that kind of curve under the lung to indicate a spontaneous breath.
Right.
You would wait until there was one where you didn't see that kind of curvature for that spontaneous breath, and then chart that tidal volume when it was red.
Right. Are they on a dialed in rate?
Yeah, they're on like SV or SIMV.
Oh well, that's just a controlled breath versus a spontaneous breath.
So the
That's all it is.
So the only, okay.
Yeah, that's all it is. Because one is being delivered by the machine, one's being delivered at a pressure support of X,